In today's video, we're talking about blood in the urine, and the medical term for that is hematuria. And we're going to talk about it in different functions. So there's rare cases where it can be in bladder or kidney cancers. It also can be caused by stones, and we're going to cover that. We're going to talk about prostatitis and BPH, and we're also going to talk about it in post-radiation. A lot of patients don't realize that blood in the urine may be a side effect of radiation, and they want to know what to do. So today we're talking to Dr. Wayne Brisbane. He's the assistant professor of urology at UCLA, and he's going to talk about these different instances, what we can do to eliminate, okay, if you have blood in the urine, what is the most extreme case versus what may be the most common, and how to talk to your urologist about these issues. We're here to talk about hematuria today, and thank you so much for being here. You know, I appreciate you and just taking the time to do this. I think oftentimes when men, they don't even know the term hematuria. I think a lot of guys who are probably clicking on this video are seeing a thumbnail that says, there's blood in my urine, and they want to know what to do next, or what is it, what's the cause. So can you define blood in the urine, otherwise known as hematuria?
Yeah, and you kind of did. It's hematuria is blood in the urine. We classify it into two kind of risk buckets. So there's blood in the urine that you can see, and we call it gross, which is not like gross like an ick. It's just gross as it's the histology gross, so you can see it visually. So there has to be several RBCs, like several ounces or volumes of blood in order to see that. Iron is a really easily visible thing, so it doesn't take a ton of urine. If you put like a drop of food coloring into the urine, it starts to turn from that yellow into a rusty color, and a couple of drops, it starts to be something you can visualize. So it doesn't take a ton, but that's in contrast to microscopic hematuria, which is something where the urine looks yellow or clear, but when we look at it under the microscope, we can see a couple of red blood cells. And so that's an important designation because the risk of something bad happening is much higher when you can see blood versus when it's microscopic. And so that's one way that we classify the difference. But really it is just blood in the urine.
So when I think of microscopic blood in the urine, you know, you have to get a urine analysis, as you said, in order to find that. But what would be the cause? Would it be a discomfort or some pain that would cause somebody to get a urine analysis? Like, what's a situation where you would get it?
Yeah, so there can be a couple of different scenarios. That usually would be things for the microscopic hematuria would be some other symptom. They can be urinary symptoms, urgency, frequency, pain with urination. Obviously, people with UTIs, urinary tract infections, get them quite often. There can be blood that's just caused by the bacteria or the viral infection, so that's not perfect. But you can get a lot of different reasons for urination, or for urinalyses. Also, kidney disease and things like this is where the kidneys are not working as well. So we're picking them up, and the patients can oftentimes be like, whoa, I didn't realize that there was some blood in my urine. And depending on how much blood is in the urine, it may not be an issue. At the American Urological Association kind of substratifies microscopic hematuria into risk classifications. And so if you're younger and you've never smoked, and we can talk about smoking and why that's important, but and you only have less than 10 red blood cells, that may not be a huge concern. If there's more and more, or if you have a history of smoking, a little older, men classically, those gentlemen are at either risk of kidney cancer or bladder cancer, and those can present as blood in the urine.
So in situations where somebody sees blood in the urine, is the first thing they're going to do get a urine analysis? I think a lot of times patients are probably calling the primary care physician.
Yeah, sure.
Is the primary care physician going to get them to your urologist right away? What's the flow?
One of the issues with hematuria is just figuring out the diagnostic modalities. So a lot of people will hear of these dipsticks urine, where you kind of dip a chemical swath and then look at it compared to a color, and that reaction is what's classifying blood in the urine. Those are really good tests as a screening test, but they're not definitive for hematuria because protein, especially myoglobin, which can be normally excreted in the urine, especially for people with kidney disease, that will cross-react with the blood, and so you have to do a microscopic analysis. So if you have some blood in the urine, or if your primary care is asking for blood in the urine and then you come to see a urologist, for example, one of the first thing I do is actually have it under a microscope where we look for red blood cells, okay? Because those really shouldn't be passing through the kidneys and into the urine. There's some breakdown in the urothelial lining, which is a waterproofing lining, coating the kidneys down to basically the tip of the urethra. We have to confirm that it actually is microscopic hematuria, so the dipstick is not quite sufficient. It has to be microscopic, looking at it under the microscope. At some point, those patients will transition over to see a urologist, usually. The urologist at that point can tell the patient, you know, you're really from the top of the kidney down to the tip of the penis is going to be the locations with which we can have anything that can produce blood in the urine. There are a couple like tips and tricks. So if you're seeing blood in the urine and you're seeing it all the way through the urinary stream, that's usually above the level of the prostate, because obviously the blood is mixing in the bladder and kind of sitting there, and then urination coming all the way through. If it's at the beginning or at the very, very end of the urination, it's usually distal to the prostate, or so the prostate and urethra style of things. So that's kind of an anatomic isolation. Not perfect, but it's important. Let's say we want to further this evaluation. So it's like, hey, this looks like it's a little bit more. Either you've seen blood, or a history of smoking, or a little older gentleman, older female as well. We want to do an evaluation of the bladder and urethra, prostate, and also the upper tracts. So that's going to be the kidneys and the ureters. And so that requires two parts, right? We can only go so far with one of these little fiber optic cameras. So that's cystoscopy, is looking inside the bladder with a fiber optic camera. And then there's looking at the ureters and kidneys, and that's oftentimes done with a CT or an MRI. Also an ultrasound if it's very low risk disease. So it's kind of a multi-step process. So I'm happy to talk about them in sequence. So we'll just start with the upper tract. So this is the kidneys and the ureters. Kidneys and the ureters can have hematuria produced by multiple different things. Some of the classic ones are going to be kidney cancer, urothelial cell carcinoma, which is the lining of the kidneys, and kidney stones. Okay, so those are pretty simple. There's also some other kind of, we call them zebras, but very rare things that can happen. So you can have inflammation of the kidney that can be infectious with bacteria or virus. You can have abnormalities, actually like functional abnormalities, the way the kidney is formed. And then also same thing with the ureter as it goes down. But that's diagnosed with some kind of imaging. And so oftentimes they're called a urogram. So this can be a CT urogram or an MRI urogram. It doesn't really matter. Obviously, the clinician will choose which one works for that patient. But like young females, for example, might go with an MRI, or younger patients might go with an MRI, where older patients with the radiation exposure might not be as much of an issue. And they're a little faster scan. You don't feel like you're in this kind of more secluded area for the MRI. All those things important, but you have to really take a look and make sure it's not a kidney or ureter pathology. And then the other thing is a cystoscopy. Patients obviously don't love these cystoscopies. They're not comfortable, and I totally appreciate that. But unfortunately with bladder cancer, it can grow flat against the wall of the bladder. So there's not an imaging test that we really can make sure that we know or we can really exclude cancer. Especially there's this concept of carcinoma in situ, which in bladder is kind of this carpeting of cancer against the bladder wall. Very invisible to imaging, but quite visible on cystoscopy. And so the cystoscopy is the best thing we have. We have been trying to do some urinary biomarkers. These are either cell tests or DNA tests where we urinate and collect them. Some of them are kind of showing promise and in clinical trials, but I would say at this point, the kind of gold standard is going to be anybody who's at moderate or significant risk for one of those issues, being cancer or something else, is going to get a cystoscopy, which is looking inside the bladder, and some sort of imaging of the upper tracts.
Before I get to my next question, I just wanted to let you know that in September, we are having a prostate cancer patients and caregivers conference, and it's a great way to get your questions answered by world-renowned experts in person. You can learn more at pcri.org/conference. A great way to support our channel is to click the subscribe button. When you do this, it supports our cause, and also you can donate to PCRI at pcri.org/donate. Now back to my conversation with Dr. Brisbane. So when it comes to the upper tracts, if you have a situation where maybe, I love that you talked about where is the blood when you're urinating. If it is just towards the end, as you said, are they going to go ahead and still do the imaging up top to see if it's in those upper regions, or is it going to primarily just rule it out?
It's a good question. I think with a lot of experience, you can kind of isolate into a tract, but it's a big risk on the clinician's part and obviously the patient's part as well to say, well, this is the only thing we're going to look at based on your history alone. And oftentimes when I talk to patients, I'm like, okay, well, if it's only the first or distal portion of the urinary stream, then they start to second guess themselves. Well, I only saw it in the toilet, and once it hits the toilet, it's red all over. So it does put you in a tricky position. That's just something in the history that I use to kind of give you a statistical chance of where you want to go, or where I'm going to be focusing. Because oftentimes, to be perfectly honest, we only find something that was wrong about 10% of the time. So it's actually oftentimes a completely negative workup. And we consider that a win. Obviously, we don't have a malignancy or there's no kidney stones sitting up there or something like that. But you can imagine for the patient's perspective, they want to know, why did this happen and will it happen again? And so that can be very frustrating to know exactly what the issue is. Oftentimes the prostate does get blamed. So when you rule out the kidney, we rule out the ureter, we rule out any bladder cancer, we say, well, it could be the prostate. And one of the reasons is because the prostate is a pretty good culprit. It can get very large. It can be a source of inflammation. Obviously, there can be prostate cancer, but actually prostate cancer most likely will present with an elevated PSA. Very rarely that it would present with blood in the urine. But you can have things in the prostate that just get big, and just like, if you got a bloody nose, nobody would be really worried about it. The same thing, this is just a normal fluid that can get stained with blood. And if we don't find anything, often it's considered a positive.
So that's an interesting statistic when you think about that 90% of the time, it's not something that can be tremendously scary, and it may just be a issue related to the prostate or any of the other situations. So let's just break it down, from the most extreme situation where maybe or more intense situation where somebody does have something like bladder cancer, versus breaking it down to something where it's just maybe BPH or prostatitis specifically for those types of issues, or any of the other issues like kidney stones. How often do you see that men who are seeing blood in the urine are going to be diagnosed with something like a bladder cancer? Like, what is that percentage likelihood?
It's a little bit, it depends a little bit on the exposure that the man has had. So if you're looking at an 80-year-old male with multiple years of history of smoking or firefighting or some kind of occupational exposure, anything with a benzene ring, and who knows what a benzene ring is, but like diesel fuels, cleaning solvents, these are kind of anything you can think of that's going to sit in the bladder. And those toxins, just like the lung is filtering things that we're breathing, the bladder is kind of sitting there and in contact with these chemicals for long periods of time. And so those gentlemen are at considerable risk for bladder cancer. And so we do find it as much as 25% of the time. But if I'm looking at a 25-year-old female patient who's an vigorous exerciser and she sees blood after a long run, I'd be very, very hesitant to ascribe a pathology to it. Yeah, it could happen, but you're looking at less than 1% of the time.
Because there's joggers hematuria, right?
There really is, yeah. So you can, just like, the lining of the bladder is very, very impermeable to fluid. And so it's one of the most waterproof layers of our body. But it can crack just like anything else. Your mucous membranes, your nasal passages, skin, lips, anything can crack. So you can have these little blood that will come in. And so it's really important to risk stratify those patients. But for the men who are at risk of bladder cancer, it is a real malignancy. Bladder cancer is extremely aggressive and it can end your life. And so that's why, as urologists, we take it very seriously. The other malignancy, kind of one step below that, is going to be kidney cancer. So kidney cancer is something that we do take very seriously. It's less associated with smoking, though smoking is an issue, but hypertension, which is extremely prevalent, can cause kidney cancer. It's also a genetic disease in many, many families. And so you can get these things where you have heritable malignancies in kidney cancer. One of my colleagues, Brian Schuck at UCLA, has built a kind of a familial kidney cancer program for people who are very interested in kind of figuring out their risks, and he's a world expert in that. They also have a very cool one at the National Institute of Health. But most men or women who are in that kind of familial risk group, they know it. They've seen family members go through kidney cancers. The ones I worry about are kidney cancers that are just spontaneous. You can't feel kidney cancer, so you wouldn't know. They can get quite big before you would ever see them, and so that's one of the things we do worry about, because that will present initially as blood in the urine. So those are two of the ones that we see. I think most of your viewers know about prostate cancer. Prostate cancer is extremely prevalent, but again, doesn't oftentimes present with urinary troubles. That would be very advanced prostate cancer. So I think that's going to be a lower kind of issue. But there's other things that will cause hematuria that are non-malignant. Okay, so kidney stones, one of the big ones. You can have inflammation, either UTI or nephritis or pyelonephritis. And so that can be difficulty. Obviously, if men or women are presenting with an infection where you can clearly see their temperatures going up, their white blood cell count is going up, and then we see hematuria on top of that, that's much less risk than if they're just presenting, they look fine.
So I always hear kidney stones, bladder stones. Which one is more common, and do they both present with hematuria?
Good question. So kidney stones are more common. Kidney stones and bladder stones they're obviously both stones, but they are formed in very different ways. So kidney stones are usually kind of a metabolic issue. Patients are forming them due to a difference in the salt concentration versus the urine concentration. The biggest risk factor is going to be lack of fluid intake, but you can also just have a salt-forming phenotype. So there are some patients who say, I've had 7, 10 kidney stones in their life, and some people who've never had a kidney stone. Those who have had multiple kidney stones will probably have some kind of either genetic or dietary predisposition to forming those kidney stones. Kidney stones form up in the kidney, as their name derives, and they can definitely cause hematuria as they're kind of bumping around, but most of the classic presentations for kidney stones are going to be the flank pain, that really, really terrible debilitating pain when they're trying to pass from the kidney down into the bladder. Bladder stones oftentimes form from a completely different mechanism. It happens to be where you're just not urinating efficiently, or for some kind of foreign body, and this is the bladder is more sedentary. The urine has more stasis there because it's sitting, waiting between voids, and so you can have the stones form, and this would be guys with really large prostates, women who have inefficient emptying, spinal cord injuries, strokes, anything that limits the ability of the urine to come out, and so those are going to be the bladder stones. Both can present with hematuria. But oftentimes we will know something from the history. So for example, a kidney stone former, they say, God, I had this terrible pain in my back. I've had a couple like this. I knew exactly what was happening. I went to the emergency room, flash of blood coming out of the urine, and that was it. Or men who saying, wow, I've just had debilitating urinary issues coming and going, and it's been getting worse and worse over time. And when we do a CT scan or an ultrasound, you see a stone that's usually pretty large sitting in the bladder and rolling around. Hematuria might be one of the results of that diagnosis, or it might be the thing that cues us into that diagnosis.
So talking about cystoscopies, when I watched a couple YouTube videos, and in those YouTube videos, I have to admit, I've seen a lot of prostate-related issues. I've seen a lot of BPH issues. I've watched so many procedures, and that looked incredibly painful. Now, there was a metal rod. There was kind of like a rubber one that they used for the camera. It was much thicker than I thought, and I know it only lasts 2 minutes, but a lot of these guys aren't, they're not under anesthesia. It seems like there's a local, if I'm correct. So because this seems like quite a painful event, is there anything that a patient can do ahead of time, or is there anything that they should ask the urologist to help alleviate some of the pain? Because it looked pretty intense.
Yeah, no, I think you hit upon a classic dissonance between physicians being normalized to a procedural event where they're just kind of this is part of our life and we just do it for hundreds and hundreds of men and women per year, and it's just toughen up. And for patients, this is the one time where they're being experienced, and they're where you're going to put that where, and this clearly it doesn't fit, and all
right. And
just
to clarify, it goes up the penis, which I think a lot of patients were not expecting. And I was reading some of the comments even from our YouTube channel, and they said, I went into my doctor just to check, and then I just found out that I'm doing this. So that was kind of a new situation.
Totally. I won't downplay it. The procedure is definitely not something you want to do on vacation. The caliber of the urethra is about 30 French. And the fiber optic cameras that we use are about half that, so about 16 French.
And French is the measurement of how
French is the measurement of the diameter of the instrument where they're using. It's about the size of a computer wire, not one of not an industrial cable, and not a telephone wire, but one of those computer wires that usually you use for plugging in a laptop or something like that. We can absolutely do them under anesthesia, so there is an option to do that.
Now, when you say anesthesia, is that at UCLA or is that common across urology?
No, that's something that we can do at UCLA. But what I tell patients about, we can do this under anesthesia, but let's take a step back and say, do you really want this? If you do this under anesthesia, you need to make sure that you meet with your primary care doctor to make sure your heart and lungs can tolerate anesthesia. It's a much bigger procedure. You need to have somebody drive you to and from the procedure. You have to have somebody stay with you overnight in case the anesthetic causes issues. You have an incremental, or some would say exponential, but a huge increase in the amount of cardiovascular and pulmonary toxicity that could result. Obviously, it's usually very safe to have anesthesia, but it could result. The other thing is that it's just not that much of a procedure as far as duration goes. When I talk to patients about that, and they're like, oh yeah, I would have to take this amount of time off work, go and see my primary to get anesthetic clearance, have somebody stay with me overnight, drive me to and from the procedure, so it's not just my day, it's other people's day who's getting involved. In the end, a lot of patients say, oh yeah, this is worth it just to do it under under local anesthetic where we put some lidocaine down the urethra and stuff like that. There are some technical things that can be done, and a couple of researchers, Angie Smith and John Gore, who you have to remember, some patients with bladder cancer get this every 3 months. And so it's a huge kind of research initiative for them to figure out how do we do this. So there's some initiatives where we're trying to actually like use smaller cameras with fiber optics that are interpreted by AI, but other things where you can like change the water pressures that are going in to kind of help get the fiber optic camera in quickly. So a lot of urologists do know how to do those, but it's important to just kind of definitely advocate for yourself, which is, I think, a really big theme on this channel, and say, is this something that you're going to be okay with or not? And so specifically at UCLA, obviously I can't change the world, but at UCLA, I will say that we have a couple of things that we do. So one is we use lidocaine into the urethra to kind of help numb the tract. The other thing is we offer people nitrous oxide, which is an inhaled anesthetic and anxiolytic. So it just kind of makes you feel floaty, turns down the anxiety. And the nice thing is it metabolizes within 10 minutes, so you can drive yourself home. So it's a kind of relaxation without having to do quite so much. The other thing is if you kind of pressurize the water bag as you're going through the external sphincter, which is the muscle that clamps, it can oftentimes make it much more tolerable. All that to be said, sometimes patients are like, thanks, but no thanks. I'd really prefer to do this under anesthesia, and we can work with them.
Okay, that's very good to know, because when I was watching this guy get it live, I heard his pain, and I was shocked they posted it because it was quite intense. And a lot of the comments were saying, I had it and I'll never do it again, which was a huge cause of concern for me, because if you do have bladder issues and you are seeing it, but you don't want to go through the procedure again, that would be an issue, and we want to make sure that these men are getting screened. And we talked about kidney cancer and we talked about bladder cancer. Can you talk about the age of screening? If maybe older patients are watching it and maybe they have had issues and their kids need to get checked, what are those ages for screening?
We don't actually have screening tools for bladder and kidney cancer. So that's one of those problems, is we don't have a good biomarker and we don't have good imaging biomarkers. It's not frequent enough that, like with lung cancer, we're doing CTs. So we have some very good researchers at UCLA, Brian Shuck being among them, who are trying to come up with these biomarkers, either urinary-based derived biomarkers or imaging-derived biomarkers, so we can screen patients. But we're lucky in prostate cancer to have such a good biomarker for screening. And so there's currently nothing there. However, if you are an older male, traditionally male, with a history of smoking or occupational exposure, as we mentioned, you're at an increased risk for bladder cancer. And so any kind of blood in the urine, or even microscopic blood in the urine, is going to have much lower threshold for doing an evaluation. Women actually have to be really careful about bladder cancer, because women tend to get diagnosed at a later stage, because they are oftentimes blood in the urine is just attributed to inflammation in the bladder, usually from UTIs. So women who have consistent sterile hematuria, meaning that you go in and it feels like there's some burning and there's blood, but there's no bacteria, and it happens even if you get an antibiotic, it just doesn't seem to make a difference. We should definitely work those women up, because there can be cancers that are latent. Now, I don't want to make anyone super worried about this. These are definitely rarer than some of the other, like breast cancer, prostate cancer, lung cancer, colon cancer. Definitely rarer than those. So I think that those are cancers where we have good screening tests, and we want to make sure that we continue to do those screening tests. And then if you just look statistically, it is more common to get a UTI than to have a bladder cancer. But if something doesn't seem right, we definitely want to make sure we investigate.
One of the things in my research, in this channel, we've talked about CX bladder, we've talked about, I think they have Galeas, if I'm saying it correctly. I know that there's bladder care. To me, when I think about those, are those alternatives to cystoscopies? But you said they're not as accurate. So, from a screening perspective, I guess there's two questions. Number one, can I get those instead of, having a procedure where I have a camera going up in a very intimate place?
Yeah.
Or can I, use those for screening in cases where patients are in those situations, even though these are rare cancers where they have had a history of smoking and they're post-40. Yeah. So in that area of just having an alternative to a cystoscopy, is that possible?
The answer is hopefully in the future. We're not quite there yet where we can trust the test on a wide scale, but I think that we're making some really great leaps forward. And so this is going to be both looking at RNA and DNA within the blood or within the urine, which is the bladder. I think one of the ones you mentioned is a multi-panel test where you can kind of get a blood test and you can kind of screen for a bunch of different genetic sequences. Prostate doesn't work well for that. Bladder may. I wish I could tell you one way or the other that that's totally going to work, but we have to, I think, be careful within the screening population. Obviously, you're taking healthy people who are just living their lives, and you have to have a pretty good suspicion and a really high level of evidence in order to make sure that we don't over-screen people or cause them to go through unnecessary medical procedures. So they're at least not on guidelines yet, is what I'll say, but I'm hopeful in the future they will be.
In a previous conversation that we had before we started filming, you were talking about kind of these new guidelines that are coming out where the AUA is saying, yes, in this situation you have to get a cystoscopy, and in these situations you don't. So what would be the differentiations between those?
Sure. For those who don't know, the AUA is the American Urological Association. It's really done a really great job, in my opinion, of putting out guidelines for urologists to kind of help guide traditional care and or kind of standard care. And blood in the urine, something as urologists we see a lot of. So the first step is to confirm the diagnosis, as we talked about, getting a microscopic evaluation. The second step is a risk stratification, and it's multifactorial. One is the amount of red blood cells that you see. One is the age, smoking status, genetic worries for genetic risks. But once you put somebody in one of those risk buckets, so there's a low risk bucket, intermediate, and high risk bucket, you counsel them on what they need. So if you're in the low risk bucket, it's actually optional to do the cystoscopy. And sometimes you can do an ultrasound for the kidney rather than doing full cross-sectional imaging. If you're in the intermediate risk bucket, oftentimes we do recommend a cystoscopy, but we can change the way that we do the imaging. And if you're in the high risk bucket, oftentimes we recommend the full deal, cystoscopy and going to be the imaging. Those are publicly available guidelines, so patients can look up exactly which risk stratification they fall into.
So we're talking about prostatitis and BPH-related hematuria. You talked about that the prostate kind of is a known culprit, and it's really related to a lot of issues. You know, we have the urethra going through the prostate and having that inflammation that causes that clenching down on the urethra where men can't urinate properly. And then you have situations where the prostate's just inflamed with prostatitis, which is known as an infection. So these are really common situations. And in our world in prostate cancer, not even just in prostate cancer, just in prostate-related issues, especially in your world with urology, you know, we see these patients and these comments coming in and saying, I have both, I have all three. It seems like it's super common that men can just have multiple of these issues. So how do you differentiate between what is prostatitis, what is BPH, and, you know, prostate cancer not being a cause of hematuria? You know, how are you going in and saying this is the cause of the hematuria and this is how we can help?
The prostate is part of the evaluation. So getting a PSA, doing a digital rectal exam, making sure that men don't have a very obvious cancer that is the cause of this. And so in my shop, that also looks like oftentimes if the PSA is indicative of any concern, getting a prostate MRI, which is a very good thing to kind of evaluate the size of the prostate so you can get at least an indication of BPH. Obviously taking into account the patient's symptoms. Are they walking in saying, yeah, this is the first time I've ever even known about my prostate, versus I'm getting up a ton, I'm urgency, frequency, it's really debilitating, and this just happened to happen on top of all those things. We're using all the diagnostic tools. So PSA still is one of the best biomarkers we have as far as risk categorizing men, and for prostate cancer specifically. Obviously in the setting of prostatitis, it can be thrown off, but I think of PSA like a thermometer for your prostate. Just like if you were running, your temperature could go up, and if you're sleeping, your temperature could go down. Well, there's things that make the PSA go up and go down that don't have to do with prostate cancer. And so it's one of the problems with the test is it will kind of go up for no reason. But we can also compensate for that with either repeating it, other biomarkers, even free PSA, which are pretty simple, PSA density, and then imaging like MRI. So kind of risk stratifying the PSA, figuring out, does it make sense? MRI can be a really powerful tool because you can delineate risk features based on age, ethnicity. There's a couple calculators we have at UCLA. If you just put into Google like MRI prostate cancer calculator, it should come up. But you can put in your MRI features, your PSA, your age, and it will spit out a risk for prostate cancer. So using all those features to kind of say, is this prostate cancer? But I think in the setting of hematuria, we want to make sure that it's kind of exclude the bad things first. So kidney cancer, bladder cancer, kidney stones, and then prostate cancer, and we'll follow that if it is an elevated PSA. Oftentimes, I think maybe to your question, is patients want to know, well, it's not any of those bad things. What do we do now? And that can be tough because sometimes I can say, well, this is prostatitis. Sometimes I can't. Oftentimes with guys who have symptoms, we'll go down that symptomatic pathway. So meaning there, I have really bad urinary symptoms and it wasn't hematuria, and we'll say, okay, let's address your symptoms. As far as like what's the most bothersome symptom, we'll go after that symptom specifically, and perhaps those are concordant. The hematuria was a prostate-related issue. Alternatively, we have guys who have no symptoms. This kind of came out of the blue. And in those cases, I don't always have a good answer for them, to be perfectly honest. Sometimes I'll say, hey, look, yeah, this is something that happened. I'm glad that it's nothing bad that I can tell you right now. We probably should continue to monitor you, like get another urine test in a year or so. If it continues to be positive, maybe reinitiate a diagnosis workup at that point. Not always perfect in the diagnostic modalities, but oftentimes when it's not something bad, first, then I'll go and take a look at do people have symptoms that are really bothersome to them, and then actually attack those symptoms. But if guys walk in and they say, hey, I don't have symptoms, it kind of came out of the blue, thanks for letting me know, and they're okay with that, then we'll just continue monitoring them for a couple of years and make sure it doesn't recur.
And then the monitoring process, they're just getting repeat urine analysis?
Yeah, oftentimes. The current guidelines are kind of a little soft on the recommendations because we don't have really good data on this. But oftentimes it's another microscopic urinalysis evaluation for another couple of years. If it continues to be microscopic or specifically if there's uptrending amounts of the red blood cells, we'll reinitiate that evaluation just to see if was there something specifically what we're looking for or worried about is this carcinoma in situ of the bladder, where we looked in and initially it was too small, but we definitely don't want to let that grow under our noses. So that would be one of the concerns. If you have gross hematuria anytime in those next few years, usually it reinitiates the evaluation.
In these situations, maybe you can help me understand, when I think of prostatitis, we hear infection of the prostate. Yeah. What exactly in that infectious moment with that prostate is causing blood into the urinary tract that we can see it? It's obviously breaking a wall so that there is blood, but what exactly about prostatitis causes the blood to enter?
Prostatitis, I don't classically associate it with hematuria, so I think I'm not at all opposed to saying, can you have prostatitis and also have hematuria? I would say, yeah, sure, that's the case. I don't necessarily say, hematuria, you have hematuria, well, we didn't find it, it's probably prostatitis. I think that's maybe a little bit of an oversell, but you absolutely can have inflammation from any way, and you can have prostatitis from multiple different etiologies. There can be bacterial, which is the one that oftentimes gets blamed. It can be viral, it can be fungal, and it can be chemical. So there's a lot of different ways to just have white blood cells recruited into the prostate, which is what prostatitis is, and that can cause irritative symptoms sometimes, doesn't have to, but some guys feel quite a lot of urgency frequency. Other guys, I tell them, wow, you have a high PSA. We took a biopsy of something that was on the MRI. Turned out it was completely negative, but then when the pathologist looked at it, there was a lot of white blood cells in that. You might have prostatitis. Or we can do a kind of a culture. There's this kind of, nobody loves doing it, but peeing, I take a culture, then I push on the prostate, and then we take another culture to diagnose like a specific organism in the prostate, and we are able to isolate a specific organism. Those gentlemen pretty confidently do have prostatitis, and we'll treat them as needed. But I will say that there's a lot of different styles of prostatitis, and the AUA actually does have guidelines on that as well, where we have to first delineate who the patients are, put them into a risk bucket, and then treat them accordingly.
So would you say the same thing is true with BPH then?
Yeah, I would say BPH, which the AUA also has a guideline on, but you can have big prostates, and if you look on these cystoscopies, you'll see these big veins on the inside of the prostate, and so those can, just like, again, if you were to have your nose bleed, it's an odd thing. Nobody would say, oh wow, that was just another Tuesday, but it wouldn't be crazy stressful. Blood in the urine can happen just like that. It can be turbulent flow, so men having to strain in order to get the blood or the urine through. It can create quite a bit of velocity, so that can cause one of the breaks. It can be some kind of inflammatory state, which is just the white blood cells cause inflammation, the weakening of the kind of the red or the vascular wall. Those can crack and cause some blood. It can be things that I never find an answer for, so that can be an issue as well.
So in situations with BPH and prostatitis, if you have these infections or the enlarged prostates, as you said, is there a certain amount of time where you would say, okay, Typically, in situations, if there is pressure and you do see some blood, some of these white cells going into the urine, would you say that the amount of time that somebody would experience this is like a set amount of time? Like if you have blood in your urine for a couple weeks, blood in urine for a couple months, like what would be the expectation of how long this is going to continue?
Let's say there's a gentleman, and I just treat mostly gentlemen, so that's why I keep coming into it. It applies just as well for a female patient. And they had blood in their urine, they could see it, and then they did their routine, they did the whole workup, CT scan, MRI, cystoscopy, the whole bit, nothing there. And then they go and they're continuing to have blood in the urine, and they call me like, hey, how long is this going to happen? I usually tell them I don't expect it to go for much longer. So if you really diagnose somebody with no issues, and I say, I have no idea what this is, then I would expect it to resolve within a few weeks. That's my expectation as a urologist. I can be wrong, but that's my expectation. If I go in and as part of the evaluation, I'm like, wow, your prostate looks really like there's an issue, a big blood vessel right at the bladder neck, and it was oozing a little bit. That could kind of come and go, just like if you had a scab, it could kind of bleed and stop. That's pretty common. So I would tell them, obviously, in your particular case, I think there's a good explanation for this hematuria. Don't worry about it. It could last a little longer. And then obviously we use this, a 25-year-old female who's exercising. Then I would expect it only to be around the time of exercise. And I wouldn't expect it to be that much longer. So I will obviously, based on the patient's risk factors, give them a little bit of clarification. It's not the normal state, as you alluded to. So I don't think that we should kind of let this go on in perpetuity without kind of trying to figure out what's going on.
So in situations where maybe all of those things, as you said, the more serious things have been rolled out, and a man, maybe does think it's related to his prostate, then if you say it's kind of continues to be ongoing after weeks, maybe 4 weeks, 6 weeks, then it may be a different issue that they need to look at?
It's possible. The other thing that can be helpful is those anatomic differentiators that we discussed. So is it truly kind of terminal hematuria, where it's like, is it a couple of drops of blood at the very, very last bit of your urine? And that's much, much more classic for something prostate, even distal to the prostate, actually. Men will tell me, well, it's a kind of a big blood clot right at the beginning of the urinary stream. That's usually something that's kind of pooling in the prostatic urethra and then gets pushed out right at the beginning. So when I hear those kind of anatomic cues, I'll think, oh yeah, that's much more prostate specific. The other thing that's interesting is obviously the prostate is surrounding the urethra, but there's a couple other organs that are in that direct area, the one being the seminal vesicles. And so you can have blood from the seminal vesicles, you can have blood that's kind of pooling in the ejaculate, and blood in the prostate that's kind of leaking out through the verumontanum, which is kind of where everything connects to the urethra, and then get that pushed out. And that's another broad topic. But we don't consider hematospermia, so blood in the sperm, even though it's a very scary etiology, but we don't consider that to be much of a risk factor for prostate cancer. So you can have the bleeding in the prostate either from vascular malformations, meaning that a part of the prostate just kind of outgrows its blood supply and has a little trickle of blood, or the way that the arteries and veins match up doesn't meet up. Obviously, trauma is we'll just assume people knew about that trauma, but there can be things that happen, and I'm sure, as you know, when patients following biopsy, they'll have some blood in the prostate, and that goes on for a long time. So you can have sequelae from trauma that goes a little longer than men were expecting.
So what about hematuria in situations where men are post-radiation? I think a lot of men don't realize, I find a lot of patients don't understand the side effects of what they're going to go through once they're, deciding upon a treatment. Yeah. And on this channel, we talk a lot about quality of life, and we talk about knowing your side effects ahead of time, some of which can be mitigated when talking to your doctor and others which can't. Yeah. We have thousands of radiation patients who have watched this channel, and many of them have raised concerns that they have experienced blood in their urine post-radiation. Yeah. How long does that typically go on for, and is it a permanent thing?
Radiation is a really great treatment for prostate cancer. So what it does is it preferentially kills things that grow fast, and prostate cancer grows fast. But there are other things around the prostate that grow fast as well. One is the rectal mucosa. Thankfully, with you have these hydrogels now, you can push the rectal mucosa away. But one thing you can't push away is the waterproofing layer of the urethra and the waterproofing layer of the bladder. And those grow very fast in order to kind of have cells regenerate them to keep the urine where it needs to be. One of the problems or sequelae, it's a known thing, so it's a sequelae of radiation, is there can be cracks in the urothelium that cause issues. And so that can be experienced in an acute phase. Obviously, for that first couple of months surrounding radiation, oftentimes men will experience three things. Urgency, kind of the feeling like the bladder is just, I tell them it's like a jalapeno pepper in the bladder, that kind of feeling. Frequency, having to just the amount of urine that they usually can hold, they're not able to hold that much. And dysuria, which is pain with urination. And all of those kind of have to do with, the bladder is holding things that your body's trying to get rid of. Salts, acids, a lot of different kind of materials that hurt. Urothelium is meant to be impermeable to those things. When it cracks, the layers below it can feel those things. And so that's going to cause, urgency. You're going to feel like with just a little bit of that salty acidic urine, you want to get it out. Frequency, you just can't hold as much of it. And then dysuria, when it's passing through, it burns. And thankfully, oftentimes that's a transient issue. The other urothelial cells will go down and populate the rest of the urothelium, and they'll regrow. And so oftentimes we see this kind of abate within a couple of months, maybe 6 months, but it's oftentimes transient. But you can have issues where those cells don't regenerate as they should, okay? And that is oftentimes characterized as something called radiation cystitis. That's a general catch-all term. It comes in multiple different gradations or severities. It can absolutely be happening with hematuria. Now, if all you're seeing is blood in the urine after radiation without anything else, it still deserves some kind of evaluation, because one of the other concerns with radiation, though it's extremely rare, and I want to emphasize the rarity, but radiation can also induce malignancies. And so you can have bladder cancers that are coming after radiation. Extremely rare, but it's an important consideration. And we take it pretty seriously if somebody's had radiation, to not think that, oh, it's just radiation cystitis, no worries. So those patients, actually, I do really, almost canonical about, you really need to make sure that we go in and evaluate this just to make sure that it's not a tumor. Let's say they get a perfect evaluation, we don't find anything, it's just kind of a cracking of the urothelium. That is oftentimes as well transient. We do have a couple of patients who will get into trouble where the bleeding in the urothelium, it can't correct itself. There's a couple proteins in the urine that act as a natural anticoagulant. So they don't allow the blood to just use their normal clotting factors. One of the problems is you can also still form some congealment, and then they can form a clot and they'll go into urinary retention. That's a really tough scenario. But once we get patients through that, we're like, okay, we got you urinating, okay. There's these new therapies that can be really phenomenal, which is hyperbaric oxygen. And those therapies actually induce new blood vessels, kind of this neoangiogenesis, to kind of help the urothelium regenerate and get some of the blood that it needs in order to stop breaking. So oftentimes UCLA, as do many centers, will have patients go under these dives, which is a 90-minute treatment where they're increasing the oxygen and the pressure in order to increase the oxygen carrying capacity of the blood and deliver the oxygen to the cells that are kind of not doing as well. So it's a really very interesting treatment. It's something that has gained a lot of steam in the last 4 to 5 years. And it seems to be a very, very good treatment for radiation cystitis.
Yeah, it was interesting. I was reading some comments from some previous blood in the urine videos that we did, and there were multiple patients who went in and had the hyperbaric chamber experience, and it seemed like, they bought 40 sessions, and on session 11 or 12, it seemed to have worked, and we had some patients that were even like a couple years out, a year out, and they weren't seeing any issues. So it's really exciting that there is something like that. Outside of hyperbaric chambers, when we're talking about, transient blood in the urine post-radiation, we're talking about a couple months. Are we talking about a situation where it's now permanent?
It can be. I've seen very few patients where they just, that's their life, right? They did radiation, now they just see blood all the time. That deserves an evaluation. Most patients, you get radiation and you'll have your transient radiation kind of changes, urgency, frequency, dysuria. That should go away, and then you'll pee normally.
And what time frame should it go?
I would say, at least within 12 months. Oftentimes, the radiation oncologist that we're using at UCLA, I see patients recovering within 2 to 3 months. That's a spectrum, but it is especially with the way we're able to target radiation. So we have an MRI-guided linear accelerator where they can use MRI rather than CT to kind of focus just on the prostate. We have a really strong brachytherapy program where they're like putting the needles and the radiation's coming from the inside out. So with those types of technology, I see pretty good urinary side effect profile. But not everyone is like that. Also, I should shout out to Dr. Kishan, who's a radiation oncologist. He's developed a kind of a genetic test that can kind of risk stratify men into kind of a little bit more risky to get dose intensified, or what they call SBRT or hypofractionation, versus conventional radiation where they spread the radiation out. So he does that as a routine care. It was developed at UCLA by his group. Really, really kind of nice way to kind of risk stratify men so they never have to go through this radiation cystitis. But I would say that it should resolve. I really do think it should resolve. It doesn't for everyone. And we do tend to see it, a few years out for some reason, where men are starting to have blood in their urine and they're starting to notice this kind of problem. Now, I don't know how many patients I capture who just said, hey, there's some blood in my urine here and there, no issue. I tend to notice the ones who really have debilitating issues. They can't pee. The blood is just stopping their urine stream. And obviously that's something that you have to deal with in the hospital and requires multi-team involvement. And we got to get you out of that problem and get you over to the hyperbaric team. But I don't know how many patients, like what the delta is, guys who just have blood here and there and never have a trouble. I may not be the best person to answer that, but my impression is that it's fairly rare.
No, I think that's a great answer. Amar Kishan, we did a presentation with us regarding that, so we'll link that in the description below because I think patients will appreciate learning more about his project. So now when we're talking about, we had talked about short-term side effects of radiation, long-term, side effects of radiation, and hematuria popping up. In that middle time, we're talking about once it comes up and it gets to you, you're talking about hyperbaric chambers. So going back to my original question, is there anything else that men can do besides a hyperbaric chamber that would eliminate the bleeding?
Yeah, it's a little tough. And obviously, guys who are in the hospital for this want this to be they're like, this should be the last time this happens. Please tell me anything that I can do. And I will say that we can, to some extent, make differences. I don't know if this works, but we've had some guys do hyperbaric oxygenation at home, so they get a home unit. They don't usually get the same level of pressure at the home units, but for guys who are really aggressive, I've offered that. Some of my gentlemen, I've just been saying, be careful if you start to notice a little bit of blood, really hydrate quite a bit and then let me know. And then if you ever get into trouble, we can try and stave it off before you're in full on retention or something like that. But to my knowledge, there's no kind of regenerative pill that you can take that's going to restore your urinary lining. Hyperbaric seems to be the thing that is the best treatment right now. Obviously, with the more modern radiation techniques, I think we're seeing less of it. So this is good. Most of the guys that I treat for this radiation cystitis got an older style of radiation where they just got a bigger dose in a larger area.
If somebody, had radiation, and I know you talked about in rare cases if there is this constant and more long-term hematuria, that they need to be checked for bladder cancer and they need to get a cystoscopy. Because there is bleeding, is there any issue with them getting it? Does that cause any issues for you doing the procedure?
No, thankfully not. If there's a considerable amount of blood in the urine, it can be difficult to do visualization. We have some tricks that one of our bladder cancer experts, Kareem Chamey, does this quite a bit, where because he's looking for bladder cancer among men who have really bad hematuria, and instead of using water that distributes the blood in the urine, he'll use air. And then it just kind of looks like laparoscopic surgery, and it's you can see beautifully. Thankfully, patients don't seem to have any more symptoms, so it doesn't hurt more. Doesn't hurt less, but it doesn't hurt more. Diagnosis of radiation cystitis is currently a visual diagnosis. So you actually, in order to document somebody has radiation cystitis and then have, to use Medicare because that's what I use a lot, have Medicare pay for their hyperbaric oxygen therapy, which is quite expensive, you have to have a cystoscopy in order to establish that. So it's both for practical and biological reasons, something that we still do quite a bit.
Now, it's a good note that if somebody does, want to get hyperbaric chamber, treatment, that they do need to go get that procedure done. So that's really good to know. Now, I know that, millions of men are on statins and blood thinners and all these sorts of things. Do they have to get off of those post-radiation? How are you advising patients in that?
No, they thankfully not. So the blood thinners, they shouldn't cause any kind of increased risk for bleeding into the bladder. In fact, we work up men just the same if they have blood in the urine while on full anticoagulation or off of it. So it's not considered something where we're like, oh, just stop your blood thinner, see if it stops, and then we'll kind of reevaluate at that point. We can see how it makes a lot of sense that it could be blood thinner induced, but it's really just an integrity of the actual blood vessels that we're worried about. It's not the blood passing through them. So if there's a malignant cause for disintegrity or breaking of those blood vessels, we want to find that, but there's not anything in the blood thinners that's going to cause those blood vessels to break.
For patients who have had radiation, they have experienced this hematuria, and they've done the hyperbaric oxygen, treatment, and it is not working for them. How often does that happen for patients? And, since there aren't other options that we've talked about, do you have them try it again after a certain amount of time?
You're talking about refractory hematuria following radiation. And while rare, it's a huge problem when it happens. And so we have to, obviously we'll try the hyperbarics. Sometimes it's difficult to get people to the hyperbarics if we can't stop the bleeding. It's a big problem for urology. One of my first research projects as a resident was trying to quantify hematuria in order to figure out exactly how much blood was in the urine and predict who was going to go into clot retention and not. So it's something that urologists think about a lot because even though it happens rarely, it's a subset of patients that really have a difficult problem. So there are some chemicals we can put in the bladder that will kind of force the bladder to start coagulating. They work well, but they can have pretty significant side effects, as you might expect. And so we try to avoid that unless we don't have other options. The bladder can be removed. We do it for bladder cancer that's aggressive. But again, we do try to avoid that if at all possible. And I don't want to make anybody nervous, like they have some blood in their urine, that you're definitely not heading down that pathway. It's extremely rare. But for some patients, it unfortunately does become a reality. And we do have pathways that we can intervene on them.
On our last question, you mentioned urinary retention.
Yeah.
If somebody comes in, they're post-radiation, they've had the hematuria, they have a blood clot, they cannot urinate, and now they're going to the hospital because, unfortunately, some of the times that I've had patients call helpline, it's interesting. They don't always think, I need to go to the doctor right away.
Sure.
They're like, oh, I haven't peed. It kind of hurts. There's a problem. And I'm sitting here going, please go to the emergency room. Sir, we love you. We'd like to keep you. How often does this happen? And what do you do if it does?
So urinary retention is extremely common. I would say there's only a subset of it that actually has to do with blood in the urine. And those ones usually patients notice because it's red and it's so abnormal that they're quite concerned, as they should be. It is an emergency. As soon as you stop peeing, it will pressurize your kidneys and the kidneys will shut down, and eventually that's lethal. So you absolutely, if you stop urinating, you have to go to the hospital in order to help us kind of help you, as you mentioned. There's not a lot of ways to say it other than just please go to the emergency room.
And what do they do once you're in there?
The first thing is to reestablish drainage. So if it is from a benign cause, like let's say somebody's prostate is too big or they have a weakened bladder or something that's treatable, obviously we will put in a catheter, establish drainage. Sometimes tincture of time after that will cause it. Other times we'll put on medical therapy. Other times we'll do surgery on the prostate to help establish flow. So kind of a long pathway to get people out of urinary retention. If it's specifically related to blood in the urine, so we're talking about the subset of urinary retention from, we have this term called hemorrhagic cystitis, where it's even one step above radiation cystitis. It's so much blood that it's a literal hemorrhage. Those patients need specialized care where we're kind of evacuating the clot, getting some inflow of water to dilute the blood and get it to come back out so we can make sure that their kidneys are not suffering from this. And that's oftentimes, we'll give them maybe 24, 72 hours of seeing if they spontaneously have a resolution. Otherwise, they've got to go to surgery, and we'll go in and try and, with a cystoscopy, fulgurate the little areas that are bleeding.
Well, thank you so much for being here. I really appreciate it. I know that we talked about a lot of rare cases today.
Yeah.
Maybe not the most common, but we want to make sure to be able to give people some information about those rare cases in case they're in that situation. I often find that because they're rare, you can't always find your answers and what you need.
Of course, yeah.
Because of the situations not always happening, and we tend to focus a lot on the common situations for these. I think that when it comes to radiation, as you mentioned, it's just not something that people really think about. Is blood in the urine going to be an issue?
Sure.
So
Yeah.
I appreciate you being here today and answering our questions.
Yeah, no, I think it's important to know about that, and obviously do your research on what your expected outcomes are. I will say again that I think radiation is a phenomenal treatment, and they are very rare. So I do worry that patients get nervous about an intervention when you think of, oh God, it could cause a secondary malignancy and blood in the urine, and then I won't be able to have surgery later. It can cripple their decision making, and I don't know if that's always founded.
Thank you so much to Dr. Brisbane for coming here and filming this today, and thank you to all of you who have requested this video and have left comments on our other videos regarding these situations. Now, I understand that blood in the urine can be very scary, but as Dr. Brisbane said, bladder cancer, kidney cancers, they tend to be more rare, and if it is some of these other related issues, there are things that they can do to see it, be eliminated over time, and hopefully the blood in the urine will not continue. And it is good to know about hyperbaric chambers for situations where patients have had radiation and are still having that issue. Now, if you have further questions, you can contact our helpline at pcri.org/helpline. They're just a great way to help you do your research and get you ready for your medical appointments. I would really encourage you to go ahead and to write down your questions ahead of time so that when you walk in to your doctor's appointments, you can go in and say, these are what my focuses are, these are what my concerns are. This can help eliminate a lot of anxiety. I think a lot of times men don't tend to think about what is concerning them, and they can feel anxiety, but it's a really good thing to write it down ahead of time so you can get some clarity for yourself and make sure that you're using your medical team not just for your treatment, but also for your mental and emotional health as you are getting your questions answered. Now, when it comes to some of the assays that you talked about, when it comes to CX bladder and some of these other ones, we're going to link the information in the description below. You may also have to get a cystoscopy, but it is good to know that these new technologies are out and that they are available to you, and you can talk to your urologist and see if these are options for you. As always, thank you so much for trusting us, for watching this channel. We really appreciate you. And please remember, most of all, you are not alone. I hope you have a great week.